Hey everybody, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back with another interesting brain imaging case of the day. So I do want to start out by saying that all of the educational content found within this presentation has been completely de-identified in order to protect patient privacy. So this is our case this week. It's a patient who is a middle-aged Hispanic man who presented with headaches. I've got 6 images for you to take a look at. The image on the top left is an axial non-contrast head CT. Image in the top middle is an axial T1 weighted image. The image on the top right is an axial T1 post-contrast fat saturated image. Image on the bottom left is an axial T2 weighted image. Image in the bottom middle is an axial GRE. And the image on the bottom right is an axial susceptibility weighted image. So keep in mind, this is a middle-aged Hispanic male presenting with headaches. Take a look at these images and try to figure out what you think is going on. Okay, 3 questions. First off, what are the findings? Put those findings together. What's your differential diagnosis? And then among that differential diagnosis list, what's your top choice here? Okay, let's start by looking at the imaging. First up is our non-contrast head CT. We can see on this axial non-con CT that there's a hyperdense mass at the right caudate head, denoted here by the yellow arrow. And this mass is exerting a little bit of mass effect upon the frontal horn of the right lateral ventricle. You can see it's been effaced right where the tip of that arrow is pointing. Whenever we have an imaging finding on head CT like that, it's always wise to get an MRI. And so let's run through the MRI pulse sequences. First up, axial T1 weighted image. You can see that in that area of hyperdensity on the non-contrast head CT, we have an area of mixed signal intensity, denoted here by the yellow arrow. We've got some areas that are hyperintense, some areas that are isointense, and some areas that are hypointense on the T1 weighted image. But it does certainly look less mass-like. It doesn't look exactly like we have a tumor. Although, boy, on that head CT, it certainly looked like something was occupying some space. So whenever we're dealing with something that may be a mass, it's always wise to give contrast, assuming the patient's renal function and allergy status will allow for it. But what we'll see pretty apparently on here is we have no enhancement. The area where the arrow tip is pointing to was intrinsically T1 bright. So there's some stippled bright T1 signal intensity foci, but no true contrast enhancement. You'll also notice that we've had a prior craniotomy. We can see that susceptibility artifact along the right parietotemporal calvarium. This is something that we oftentimes see a little bit better on fat-saturated sequences because of the susceptibility effects. It warps the magnetic field a little bit. We see that blooming artifact a bit better on the fat-saturated sequences. So what does it look like on our T2 weighted sequence? T2 weighted imaging, certainly one of our workhorse sequences. We can see that in this case, it sort of follows along with the T1. We've got variable signal intensity in that area that was hyperdense on CT. We've got some areas that are very T2 bright, as you can see here at the tip of the arrow. We have other areas that are markedly T2 hypointense, very, very dark. And when it's this dark on T2 weighted imaging, we wonder if there might be hemosiderosis going on or hemosiderin deposition from remote hemorrhage. So whenever we look at something that has multiple differential areas of signal intensity, it does make us think about blood products of varying ages. Whenever we're thinking about blood products, we like to use our gradient recalled imaging, our GRE sequence. And in this case, it shows that corresponding with those areas of signal abnormality on T1 and T2, we have marked signal hypointensity. And it looks even bigger than it did on the T2 weighted imaging. So we have some blooming artifact. And that means that we do have a component of old or remote blood products here. So there is a component of hemosiderosis going on. You also note that we see that susceptibility effect along the right parietal craniotomy much better on this sequence as well. So whenever we see something like this, I think you should go ahead and bring out the big gun. And in this case, the big gun is going to be susceptibility weighted imaging in order to better evaluate what looks to be on all the other sequences as blood products of varying ages. So our SWI sequence, our susceptibility weighted imaging, is even more sensitive for blood products than GRE. And we can see that there's really marked caudate head gradient susceptibility, lots of blooming artifact corresponding to the area that we had signal abnormality and gradient susceptibility on the GRE. But there's more. If you take a close look at this image, you'll see that's not the only one. In fact, there are tons of tiny foci of gradient susceptibility all throughout just this one slice alone. And I'll tell you, the rest of the slices of his supratentorial brain had a lot more foci of susceptibility artifact as well. So whenever we see that, we need to be thinking about our differential diagnosis for multiple foci of gradient susceptibility, multiple foci of hemorrhage in this case, and some of them even have almost like a popcorn ball or a mulberry kind of look of signal abnormality, and that's a bit of a clue as to what we're dealing with in this case. So when we see those areas of those multiple foci of susceptibility, the differential diagnosis would include multiple cerebral cavernous malformations, and certainly whenever we see multiple, we wonder about syndromic things. But there's other things that we need to be thinking about as well. We need to dig into the patient's history. Have they had prior trauma? Maybe this is just really bad traumatic brain injury. Certainly he had a prior craniotomy, so that could fit with that. A bit young, given that he's a middle-aged man, to have cerebral amyloid angiopathy, but in an older patient, we might think about that. Certainly somebody who's over age 65, that would rise toward the top of the differential diagnosis. Could this patient have multiple hemorrhagic metastases? That's certainly a good thought. None of them were enhancing, so that would argue against it, but maybe it's prior treated metastases. If they have had radiation therapy, whole brain radiation, or even partial brain radiation for a prior brain tumor, these could be radiation-induced injury, or some people think radiation-induced cavernous malformations. And then it's also worth figuring out whether or not the patient's coagulopathic. Is there a reason that he's had these multiple small bleeds? Well, as it turns out, this is a patient who had multiple cerebral cavernous malformations, and these are benign angiogenically immature lesions of endothelial proliferation and increased neoangiogenesis. These are well-defined endothelial-lined hemorrhage-filled channels within the brain that lack any intervening brain parenchyma. So there's no normal brain separating these channels. Angiographically, these are described and reported as being occult. In other words, they should not enhance, although sometimes there may be some enhancement with them, particularly if it's associated with a developmental venous anomaly, a so-called mixed vascular malformation. But for all intents and purposes, and the vast majority, you will not see any contrast enhancement with these. What I want to stress to you is these are malformations. They are not tumors. So we need to stop calling these cavernomas. Anytime you see oma at the end of a word as the suffix, that suggests that we're dealing with a mass, by definition, a tumor. Well, these are not tumors. These are vascular malformations. So this is really poor terminology to call them cavernomas. The better terminology is to call them cerebral cavernous malformations. And these can present really with a spectrum of clinical manifestations. They can be detected incidentally. The patients may be asymptomatic or near asymptomatic. Sometimes they have headaches. Depending on where they've bled out, they could have neurological deficits. These are a potential source of seizures. And if they have a significant enough hemorrhage, or if they have a complication of that bleed, patients can die from this. So it's important to keep in mind. These are fortunately quite rare. The prevalence is reported at less than 0.5% of the population has a cerebral cavernous malformation, and they can really declare themselves at any age. The peak, however, tends to be middle age. So right where this patient is at is sort of the typical peak of these being diagnosed. The rate of hemorrhage within an individual cavernous malformation is variable. It may be as low as 0.25% all the way up to 6% per year. But the greatest risk of someone having a hemorrhage of a cavernous malformation is if it's bled before. So if it's bled before, the risk is much higher that it's going to bleed again. And the more often they bleed, the higher the risk of them bleeding more and more. Additionally, if they have multiple cerebral cavernous malformations, or if it's a familial cerebral cavernous malformation, they're more likely to hemorrhage than sporadic. And there's something called multiple cerebral cavernous malformation syndrome that's classically, although not exclusively, but classically been reported in Hispanics of Mexican American and Spanish descent. But as it turns out, you can see this in multiple patient populations. It's been reported in patients from Southern Europe as well. So it's not exclusively involving Hispanics of Mexican and Spanish descent, but that is sort of the classic and most common. About 2/3 of the time, these will be sporadic, leaving a third of the time that they're familial. And the ones that are familial are commonly multiple. These are typically inherited in an autosomal dominant pattern, and they can have manifestations beyond the central nervous system. They can have vascular malformations elsewhere. We'll talk about that in just a minute. There are multiple gene loci that are linked. The big three are the CCM1 gene, which codes for the CRIT1 protein. That's the most common. Followed by CCM2, which codes for the malcavern protein, and CCM3, which codes for the programmed cell death 10 protein. So those are the big three as far as the familial or inherited variety of this. So there was an interesting paper that was actually brought to my attention via Twitter, via Mark Momlick, and this was published back in 2017, so not too old, back in radiology. But this was looking at patients who had cerebral cavernous malformations, and if you take a look at their adrenal glands and you see areas of punctate calcification, that's an imaging biomarker that suggests that you're dealing with a hereditary cerebral cavernous malformations. Those probably almost certainly represent vascular malformations with phlebolysis within the adrenal glands. So whenever you see this, don't be afraid, as Mark says. Take a look at the patient's belly CT if they happen to have one. Look at the adrenal glands. That may be a tip-off that you're dealing with something syndromic. Okay, so let's wrap this up. It's getting a bit long. This is a patient who had multiple cerebral cavernous malformations. The key imaging features to know about: this patient had variable size lesions containing blood products of various ages, and that's a really critical distinguishing thing. You want to see blood products, and commonly of various ages. These will be hyperdense on CT. It's pretty common to see calcification within them. We didn't see coarse calcification here, but you certainly can see calcification. And these are angiographically occult. But as I said earlier, these can be associated with developmental venous anomalies, giving us a so-called mixed vascular malformation. So look for that association of an adjacent or an associated developmental venous anomaly, that Medusa-like enhancement with a collector vein. A couple pitfalls to keep in mind. We always think about that popcorn ball appearance on MRI as being classic, but know that there are 4 distinct MRI patterns that depend on the age of the blood products within the lesions as well as the lesion size. So it's not always that mulberry or that popcorn ball appearance. Sometimes, as this case showed, it may just be punctate foci of gradient susceptibility. Susceptibility weighted imaging is certainly our most sensitive sequence. I say go big or go home with this. So if you have a patient that has intracranial hemorrhage, you certainly ought to be pulling out the stops and doing SWI instead of just GRE. It will up your sensitivity for certain. And I also want you to keep in mind this diagnosis of familial cerebral cavernous malformations, particularly if they're multiple, because that portends a worse prognosis. They're more likely to hemorrhage. And they may, as I mentioned before, they may also have extracranial manifestations. Challenge yourself if you're a neuroradiologist. Take a peek at the belly CT. Look and see if they have adrenal calcifications. It's kind of an interesting finding. I recently described imaging biomarker for predicting cerebral cavernous malformations of an inherited or familial origin. All right, so as always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and I would invite you to check out our complete collection of Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thanks so much.